Hey everyone, and welcome to this premium explainer brought to you by IRA Education. So, look, I know exactly why you're tuning in. ECGs, electrocardiograms, are, well, notoriously tough. I mean, at first glance, they can look like a bunch of random scribbles, right? And they constantly trip students up in competitive exams like NORCET, RRB, and CHO. But today, we're going to change that. I'm promising you a highly structured, high-yield breakdown that'll make reading these graphs absolutely unforgettable. No more guessing, just pure, clear logic. So, let's learn smart, score high, and get ready to master this.
Okay, let's just dive right into it. I want to hook you immediately with a classic, high-yield, multiple-choice question. Before we even look at a single wave, we really need to know where all this started. So, imagine you see this on your exam paper tomorrow. Who invented the first practical ECG? Do you know the answer? Let's check out the historical foundation of the ECG to find out. Here's our exact roadmap for this explainer. We'll start with the basics, break down the exact math of the ECG paper, map out the electrical waves, learn the magic formula for calculating heart rate, and then tackle the absolutely crucial part, spotting common abnormalities. Finally, we'll wrap it all up with a quick exam review. Section 1. Basics of Electrocardiography. Let's establish those foundational facts, the absolute non-negotiables you've got to know before you can even think about reading a patient's chart. So, remember that question I literally just asked you? Well, here is your answer. I want you to verbally flag this in your notes as a golden question. The practical ECG was invented by the Dutch physiologist Willem Einthoven. He started his work back in 1895, refined it in 1903, using a string galvanometer to measure the heart's electrical currents, and actually won the Nobel Prize for it in 1924. So if an examiner ever asks you about the father of the ECG, Einthoven is definitely your guy.
Now, let's quickly clear up a really common point of confusion for a lot of nursing and med students. You'll often hear doctors say EKG instead of ECG. So why the K? Well, it simply comes from the German spelling, electrocardiography. There is literally zero clinical difference here. Whether it's ECG or EKG, they both refer to the exact same life-saving procedure. Good to know, right?
Moving on to Section 2, understanding the ECG paper. You really can't calculate heart rates or spot any abnormalities without fundamentally understanding the math of the grid. Let's break down the design. On the grid, the horizontal x-axis strictly measures time in seconds, while the vertical y-axis measures electrical voltage or amplitude in millivolts. Now check this out. One large box on the horizontal axis equals 0.20 seconds. Inside that large box are 5 small boxes, meaning one tiny little box represents 0.04 seconds. Seriously, memorize these numbers. They are the absolute mathematical foundation for everything we're going to do next. And why the number 25? Well, because the standard paper speed for an ECG machine is 25 millimeters per second. This is another massive, high-yield MCQ that examiners absolutely love to test. Think about it. If the paper runs faster or slower, all of your time calculations are going to be completely wrong. So, 25 is your magic standard speed.
All right, Section 3, Electrical Waves and Intervals. Now that we've got our paper figured out, we need to map the heart's electrical anatomy to the visual waves we actually see printed on that graph.
Think of this kind of like the electrical wiring of a house. The impulse starts at step 1, the SA node. We literally call this the natural pacemaker of the heart. It fires the signal, telling the atria to contract. Then, the signal travels to step 2, the AV node. This guy is the gatekeeper of the heart. It intentionally delays the impulse just a fraction of a second so the blood can empty into the ventricles. After that, the signal shoots down the bundle of His and finally explodes into the Purkinje fibers at maximum velocity, which causes the ventricles to forcefully pump blood out to the body.
Before we start looking at the specific waves, let's simplify 2 very intimidating textbook terms. Depolarization simply means contraction. Imagine squeezing your fist tightly. That's depolarization. Repolarization, on the other hand, means relaxation. Unclench your fist and let it rest. That's repolarization. Squeeze, relax. Depolarize, repolarize. Just keep that little analogy in your head.
Notice how the very beginning and the end of a single heartbeat are framed here. That first little bump you see, that's the P wave, and it represents the atria contracting, or depolarizing. The final major bump is the T wave, which shows those massive ventricles relaxing, or repolarizing, basically getting ready for the next beat. Let's rapid fire through some more golden exam points. That huge spike right in the middle, that is the QRS complex, representing ventricular depolarization. It happens fast, taking only 0.08 to 0.12 seconds. Then we have the PR interval, which is the travel time from the atria down to the ventricles. Normally that's 0.12 to 0.20 seconds. And here is a massive clinical pearl for you. If you spot a prominent U wave right after the T wave, think hypokalemia, which is low potassium. Examiners love, and I mean love, testing that specific connection.
Okay, Section 4, calculating the heart rate. Let's shift our focus to the actual math you'll be using on the wards and, of course, in those competitive exams.
Here's your magic formula. You don't even need a calculator for this. Just remember this one number, 300. To instantly get a patient's heart rate on a regular rhythm, simply count the number of large boxes between two R waves, those tall spikes. Then just take 300 and divide it by that number of large boxes. So if there are 4 large boxes between the spikes, 300 divided by 4 is 75 beats per minute. It's simple, it's fast, and it's incredibly effective for your exams.
Section 5. Recognizing common ECG abnormalities. We have officially arrived at the most crucial part of this explainer. This is where we learn to spot pathology, and honestly, it's where you're going to score your highest marks.
Let's start off with the easiest ones, the rate abnormalities. You don't even need to do the math to spot these. You literally just look at the visual distance between the tall R waves. In sinus tachycardia, the heart is racing, right? So the R to R interval is decreased, meaning the spikes are crammed really close together. In sinus bradycardia, the heart is beating way too slowly, so that R to R interval is massively increased. The spikes are spread super far apart.
So a really crucial point here is learning to tell the difference between these two tricky atrial issues. In atrial flutter, the atria are beating at a crazy 250 to 400 beats per minute, but they do it in a highly organized way. This creates a very clean, uniform sawtooth pattern between the QRS spikes. But in atrial fibrillation, the atria are just quivering. It's totally disorganized, giving you a chaotic, wavy baseline with completely absent P waves and a totally irregular rhythm. So remember, sawtooth equals flutter, chaotic equals fibrillation.
Now we need to carefully distinguish between the two types of second-degree heart blocks because these are huge points of confusion for students. Think of Mobitz type 1 like someone getting more and more tired. The PR interval gets longer and longer and longer, until finally a QRS beat is just completely dropped. Mobitz type 2, though, is much more dangerous. The PR interval is totally constant and normal, but without any warning at all, it suddenly drops a QRS beat randomly.
And just to summarize the other edges of heart block pathology, first-degree block is the absolute mildest. It's really just a consistent delay at the AV node. Every P wave has a QRS, but the PR interval is prolonged past 0.22 seconds. On the complete other extreme is third-degree block. This is a total structural breakdown. The atria and ventricles are literally no longer talking to each other. They are just beating completely independently.
Now I need you to pay very close attention here. Ventricular fibrillation, or VFib, is hands down the most terrifying rhythm you will ever see on a monitor. The ventricles aren't actually pumping, they're just randomly twitching. The ECG shows this completely chaotic line with no recognizable QRS complexes at all. This is a critical life-or-death emergency. The patient has no pulse, and the immediate correct answer on your exam, and obviously in real life, is defibrillation. You have to shock them immediately.
All right, Section 6, Final Exam Review. Take a deep breath. We've covered all the hardest parts. Let's wrap up this explainer and truly cement everything we've just learned.
I really want you to remember this. Absolutely nobody is born knowing how to read an ECG. As the quote says, hard work makes you perfect. The only real way to master this is through visual repetition. You have the rules, you have the math, and you know exactly what the pathology looks like. Now, you just need to practice looking at these graphs daily until the abnormalities literally jump right out at you.
Thank you so much for joining this explainer. If you're serious about taking your exam preparation to the absolute ultimate level, connect with us at AIIRA Education. Check the screen for our WhatsApp, our phone number, and our location in Hamirpur. Remember, learn smart, score high, and achieve success. But right before you go, let's test what you've learned. If you sit down for your exam tomorrow and the very first image you see is a rhythm strip with a uniform sawtooth wave, what is your immediate answer?